Thank you very much, everybody, for joining today and welcome. This is the Scale Neonatology programme, which is a partnership with West Yorkshire Local Maternity and Neonatal System and Uganda. And we have a series of virtual grand rounds that we've been running for a couple of years now, which are really successful, where we learn about the UK perspective and the Ugandan perspective of different neonatal conditions. So the theme for today's meeting is neonatal seizures, the causes and treatments. There's lots of opportunities for discussion and questions, so I would welcome you to put your comments and questions in the chat, and we will try to answer those as we go along, but there will be opportunities at the end of the presentations to ask our speakers some questions. Then Dave Gibson, consultant paediatrician from West Yorkshire, will do a UK case and the UK perspective.
Thank you, everyone. And so I'm David Gibson. I'm consultant paediatrician in Pinderfields Hospital in Wakefield, which is, we're actually the largest district general neonatal unit in the whole of Yorkshire. So it's a bit of an honour to be asked to speak to you all today. I'm still in my theatre blues because I've just come from a ward round, but you'll be glad to know I've handed over. Obviously, I've been asked to talk about the perspective of neonatal seizures from a British perspective. I've got some slides, first of all, on the management. I make no bones about it. I have taken these from our regional guideline, which is what we turn to. And then I've got an interesting case history at the end. So to begin by way of introduction, seizures in the neonatal perspective are relatively common. We see them even at district general level a number of times a year, and it's thought that there's an incidence of seizures in between 1 and 5 per 1,000 live births. The majority of neonatal seizures can be provoked by, are usually provoked by an acute illness, which I'll come on to in a second in the differential, or a brain insult that has may have an underlying etiology that is quite clear or suspected from the nature of the delivery. I'm talking this perspective, hypoxic ischemic situation where the baby's born in poor condition and has sustained a degree of encephalopathy. But some of these seizures may indeed be unexpected and the etiology not clear to begin with. As I've said already, the majority of neonatal seizures that we see result in this country from a hypoxic ischemic insult that the baby has sustained in the perinatal period, either in the lead up to delivery, the delivery itself, or immediately afterwards. A stroke, it may be a prenatal vascular event. We occasionally see middle cerebral artery strokes that can lead to focal seizures after delivery and are not evident during the pregnancy, or potentially in infection in term infants. In preterm infants, we have to consider as well the development of an intraventricular hemorrhage, which can be by far and away the most common cause. There are many, many other causes thereafter. These can include brain malformations, and I'm actually going to allude to that one in my case. For example, any form of neuronal migration disorder can lead to be associated with seizures. Inborn errors of metabolism can lead to seizures through the hypoglycemic events, or for that matter, raised lactate and ammonias, as well as the neuronal migration disorder associated with it. We have genetic conditions. In this country, sadly, we have neonatal drug withdrawal, and this is not in particular related to prescribed medication, but sadly street drugs that mums have been using and taking, and maybe withdrawing from, and the side effects of those, or birth-related head trauma. So that's better. So moving on, the diagnosis of seizure activity often can be subtle and it can be difficult. The appearance compared to that of an older child or an adult, where we have the classic tonic-clonic seizure activity, in generalized seizure activity, is often not seen, and the abnormal movements can be much more subtle, and much more particular to that of a baby rather than an older child. And in some respects, there can be a degree of difficulty in considering, are these normal baby movements or are these actual seizure activity? And often what we would truly classify as normal baby movements are often mistaken for that. In light of this, obviously we need a gold standard to confirm seizure activity, and clearly that's an EEG with video. However, that's not something that's available to most of us. However, in most units over the years have fairly ready access, and we have ourselves, to EEG acutely in office hours during the week. And just more recently, we have obtained a CFM, which is a cerebral function monitor. I'll come on and talk a little bit about that. And increasingly, it's been recommended and encouraged for the majority of larger units, at least, to try and have some form of cerebral function monitoring, simple EEG, to augment our diagnostic skills in confirming or refuting seizure activity. Obviously, the EEG won't detect all seizures, but it is a good adjunct to our sort of clinical acumen. And actually, where seizures are persistent and the cause remains unknown, we really need a formal EEG. So from our guideline, they've put together a sort of quite exhaustive list of movements that are frequently seen in neonatal epileptic activity. These can include generalized myoclonic jerks of the diaphragm, which often lead to frequent hiccups. As you can see, some of these are quite subtle and maybe mistaken for normal baby movements. Clonic jerking of the limbs that doesn't improve when you hold or squeeze that limb, which implies that epileptic activity that is not overcome by your own pressure on the limb. Rhythmic tonic thrusting of the tongue and lip smacking, and sometimes eye movements as well with that. Focal tonic seizures, tonic eye deviation, epileptic spasms, and then sometimes occasionally electrical seizures if we have an EEG in place. It can be seen without actual clinical features observed. This is more when we're looking at a baby who has undergone a hypoxic insult and is having continuous EEG monitoring as part of their support and treatment. With that, there are sort of a grey area of movements that may or may not be associated with true seizure activity, and this is where some of the difficulty in diagnostic confirmation comes in. We see cycling of the limbs, pedaling, swimming movements, thrashing of the limbs, lip puckering, sucking, twitching of the eyes, and generalized clonic stiffening, which can be there for other reasons other than epileptic in nature. And then finally, there are a number of movements that we see probably quite regularly, but that are clearly not epileptic in nature. These are classically the tremulous, jittery baby. That's can be a simple normal baby finding. I had a baby that just this week that was doing it regularly, and we excluded. It's more important in that respect to exclude a low blood sugar and altered electrolytes such as low calcium or magnesium. This baby had all it was normal to all of those, and we quite often see jittery babies. But again, going back to the previous slide, if you're to hold that limb, that jitteriness should stop. Mild clonus is very commonly seen in babies, as is myoclonus as the baby's drifting off to sleep, and a startle with or without tonic stiffening. It's a video clip on YouTube that just gives an idea of some of the subtleties of the seizures we see.
Dilani, déjalo, mami. Ay, Dios. Baby. Oh, baby, baby. It's okay, it's okay. Don't you have something?
Obviously, we've got to, before we come to the management of seizure activity, we've got to consider the overall underlying diagnosis. Now, there are a number of considerations that we can take into account that will help us determine the diagnostic nature of these. Obviously, sometimes the type of movements, their duration, their frequency, their correlation with EEG or CFAM. Clearly, if we have an underlying condition for which the baby's been treated, whether that be hypoxic ischemic encephalopathy, which is evident from the baby's clinical condition at birth, the history involved, and their neurological condition, along with significant blood gas and cord gas changes. We can be fairly sure that that's the underlying cause. Like today's talk is not about the consideration of how we manage HIE through therapeutic cooling, but obviously seizures can be seen in grade 2 and grade 3 HIE. In addition, particularly in this country over recent years, we've had improved antenatal screening with anomaly scans at 20 weeks. And increasingly we're able to pick up suspicions of underlying disorders such as brain malformations and conditions which may be associated with seizures and may be forewarned of that potential. So obviously where we have a clearly an unwell baby with HIE, where there is CFAM correlation, we can be clear that this is the reason for it. But beyond that, we've got to obviously look a little bit further, and that's what I'm going to go on to next. And first of all, take the history. I've already alluded to this. Looking at mum's antenatal scans, was the baby well grown? Were there anything on the anomaly scans, particularly in relation to the brain? Infection screens, known antenatal infections, such as torch infections, which is Toxoplasma CMV and so on. A history of consanguinity. Autosomal recessive disorders have an increased incidence in families married to closer relatives. Also, a family history beyond that, even if there isn't a definite consanguinity. History of diabetes, whether that be gestational or long-standing, can lead to the baby having overproduction of insulin, and as a result of hyperinsulinemia, sometimes quite a profound low sugar, which can lead to seizure activity and must be excluded. The use of prescription or illicit drugs, and any significant family history of metabolic disorders. Moving on, we've got to think about intrapartum problems, risk factors for infection, in particular prolonged pre-labor rupture of membranes, known group B strep carriage in the birth canal, and an actively unwell septic mother. Also evidence of significant fetal distress at birth, a difficult second stage in delivery, a history of an underlying cause for that, such as placental abruption, cord prolapse, any form of where there is a suspected hypoxic episode that can go on to cause encephalopathy and seizure activity. And finally, think of from a postnatal point of view, prematurity. We've already mentioned that there's an increased chance of intraventricular hemorrhage seen in unstable preterms. Late postterms, sometimes babies of low birth weight and issues of feeding can lead to low blood sugars inadvertently. And it's important to try and witness and see the seizure for yourself as a clinician. The examination of the baby, as well as a standard neurological examination, where you're going to want to look at the baby's tone, their posture. Are they hypertonic, hypotonic? What the nature of the movements? Do they have underlying maintenance of primitive reflexes, their pupillary reaction, their gag, their suck, and measuring their head circumference as well as a baseline is very important. If this baby has, for example, an evolving hemorrhage in a preterm baby, this may lead to a rapidly increasing head size, or for that matter, congenital hydrocephalus. And actually, more broadly, we've got, and thinking more widely, we've got to look at these babies, and you'll see this coming out in the case that I'm going to come to, for obvious dysmorphic features that may be reflected in an underlying syndromic condition. Neurocutaneous lesions, in particular, evidence of tuberous sclerosis, for example. I had a lovely case many years ago as a junior doctor over in Leeds, where I was asked to attend a delivery of a baby that had been picked up on an antenatal scan. There's nothing to do with seizures, but had been picked up on antenatal scan as having evidence of lesions within the heart that may cause an arrhythmia at birth. And the baby was born in very good condition, but the first thing I saw on the baby's skin on the resuscitator was a depigmented macule, which was very suspicious of tuberous sclerosis. I went to speak to mum, and she said, "Oh yeah, I've got loads of those," and nobody had ever taken a history from mum, and sure enough, she had tuberous sclerosis as well. Other birthmarks, bruising, bleeding that can be associated with a traumatic or difficult delivery, and obviously examining the functioning and stability of the other systems, cardiac, respiratory, and abdominal systems. Clearly, if there's a clear story and from an examination, particularly, as I say, by far and away the most common cause of seizures are associated with hypoxic ischemic encephalopathy. No further investigation to prove that is necessary. However, if there is no clear cause identified from first line of investigations, and we have ongoing refractory seizures, it's very clear we have to investigate further. And we have our own guideline has got, it may not show up terribly well, a sort of stepwise consideration of the investigations we would carry out. Clearly, for all babies that have seizure activity, one of the first things you want to obtain is a blood gas, and that can give you results, first of all, most importantly, of a blood sugar, which, if low, can be associated with seizure activity. It can be as a result of seizure activity that sugars drop as well, but obviously, if low, must be corrected. Furthermore, a significantly raised lactate may give an indication that there may be an underlying metabolic disorder, or at very least a poor organ perfusion, but it makes us think a little bit further. Worthwhile, obviously, carrying out a full blood count, which will we can see what the hemoglobin and white cell count and platelets are in relation to infection. It's worthwhile running some biochemistry as well to make sure we don't have significant electrolyte abnormalities. A septic screen, in the absence of knowing the cause of the underlying seizures, is mandatory, because until known otherwise, infection must be ruled out and must be managed. So a blood culture and a CRP at very least, and covering with IV antibiotics, and considering if there's evidence of ongoing significant infection, addition of a lumbar puncture, which would further tease out the possible cause, but also govern the duration of antibiotics. Where possible, at the soonest juncture, it's worthwhile obtaining some form of simple brain imaging, and the easiest way to do so at bedside is a cranial ultrasound, so that we can look for evidence of, first of all, intraventricular hemorrhage. We can get a basic idea of the structure of the brain, and some degree of evidence relating to any brain malformations or neuronal migration defects that may be associated. One case I had a few years ago was a baby with a very large head at birth, of 50 centimeters at birth, who very quickly developed seizure activity. We were expecting a hydrocephalus. Actually, when we scanned the baby, they had an in utero brain tumor that was into which they bled, which is a very unusual case that was taking over one complete hemisphere, and with significant midline shift. But that's a more dramatic and unusual, unexpected finding. More often, it's looking at either bleeds or brain malformations. And actually, as mentioned before, if we can obtain a bedside EEG, or if we have access to a cerebral function monitor, placing this on to give it further confirmation, of the seizure activity. Beyond that, if those simple tests are not forthcoming in giving us the underlying cause, we've clearly got to look a little further, and ultimately sometimes a lot further into rather small print conditions that are increasingly uncommon. But widening our diagnostic investigations, if we have a suspicion of a significantly acidotic baby, it may be important to take an ammonia, and following that, I think it's on the next screen, performing a more extensive metabolic screen to rule in or rule out an underlying inborn error of metabolism. In the absence of anything else, as well as taking CSF for culture and microscopy to exclude meningitis, there obviously are a number of other tests that can be done on CSF. Infection screening may well have to be extended to include exclusion of herpes PCR. But as our guidelines said, that doesn't often present until around or beyond 7 days of life. It can be a little later, not in the immediate newborn period. There's obviously ongoing second line of investigations if we still are drawing a blank, and as I've said, these are including a wider metabolic screen, and additional disorders as well, such as biotin deficiency, and many other quite small print situations, which we as a district general would be turning to our tertiary colleagues and turning to the guideline, obviously, for advice on how we'd move forward with such investigations at this stage. And I'm sorry, this one's quite small print, but there's actually another list that carries on beyond that, but I think you've got copies of the slides. So our approach to treatment is fraught in that there's no nationally agreed guideline in this country as to the acute treatment of neonatal seizures. There's no nice guideline or sort of encompassing guideline that everyone is using, although there's within the units across the country, we have a general consensus that most of us use. With complex epileptic syndromes, which thankfully are not so common, we as a district general level would have to be guided by a specialist tertiary neurologist. But obviously, we've got to consider, first of all, management of simple seizure activity when it first presents, and take it from there. It's very clear that we've got to take an ABCD approach. We've got to support this baby and support their airway, breathing, hemodynamics, and in that respect. Rather, we've got to think of all those aspects as opposed to simply diving in managing the seizure itself, in stabilizing the baby. If we can apply CFAM or EEG, that's helpful. Clearly, if hypoxic ischemic encephalopathy is suspected and babies fulfill criteria for cooling, then that should be commenced under our fast track policy of stabilization and transfer to a tertiary unit for therapeutic cooling. Should be undertaken within the 6-hour window of as per guideline, but I'll not talk about that any further length. Obviously, as I've alluded to begin with, we must identify and correct any immediate reversible causes such as hypoglycemia or electrolyte disturbance. And if infection is considered and suspected, culturing the baby and starting on broad spectrum antibiotics, plus or minus antivirals if there's additional suspicion of that, either in history or clinically. We know that neonatal seizures can contribute to a poor neurodevelopmental outcome, so it is important that we manage these promptly and in a timely way. However, sometimes the a decision to start anticonvulsant treatment may not be just as straightforward as that. First of all, as we've already seen, that Appendix 2 is what I've been looking at already. We have to consider, is this true seizure activity? What level of diagnostic certainty have we? And have we got electrical correlation from our CFAM or EEG? What about the duration of the seizure? If it's a single very short seizure with no hemodynamic compromise, we simply can observe, and treatment may not be required if it's very short-lived at all and not persistent. Our guideline talks about a single seizure lasting at less than 5 minutes as a rough guideline. And also, secondary to that, the frequency of seizures. If we're only seeing them very occasionally, the benefits against the risks and side effects of treatment may not be balanced at all. But if we're seeing seizures happening with a frequency of more than 3 an hour, we would consider that would merit treatment. Obviously, the more definite we are, the more likely we are to intervene and commence treatment. This is the algorithm within our own guideline of our own regional first line, second and third line medications. So actually, still in this country, we would load the baby with 20 milligrams per kilo of phenobarbital. In the first instance, see if that's settling things. Phenobarbital, as I'm sure you're aware, can be relatively sedating and can cause respiratory depression as well. So that has to be monitored when giving it. If we do get breakthrough seizure activity, we would follow. Give it 20-30 minutes, obviously, to see if we've got control. But if there's a repeated seizure activity after that, we can give a half loading dose of 10 milligrams per kilo to follow up. I think somebody put in the questions before about the ongoing consideration of regular maintenance therapy. And you can see in the box to the right, that's not always required, but if there's ongoing seizure activity that has been controlled but needs ongoing treatment, and based upon the background story, we can continue that as a regular daily dose of 2.5 to 5 milligrams per kilo, either IV or enterally, adjusted to the blood levels and the response. And actually, for the most part, a lot of our babies, particularly the HIE babies, who often have a good recovery from this and only transient seizure activity, they may actually get to the point where we have stopped the phenobarbital before discharge home, or if they do go home on it, we see them in clinic, and in many cases they have outgrown the dose because they've grown in the interim, and we can actually stop it at that time after a number of weeks. However, that's not the case with every baby, and if in the acute phase, if a loading and a second half loading dose of phenobarbital is not controlling seizure activity, as you can see, there are other additional options. Phenytoin, Keppra is increasingly used in this country for acute to stopping acute seizure activity. And beyond that, in more extreme circumstances, we're looking at a midazolam infusion, which obviously benzodiazepine. And beyond that, I've cut the slide off at the bottom. We are into some of the smaller print conditions such as pyridoxine deficiency and biotin deficiency. By the time we're getting to that point, we are discussing this with a tertiary neurology consultant. The upper part of the slide relates to our more common usage. And here's a very artificial picture of a CFAM machine. We have just got CFAM in our own hospital in the last year or so. This is either 3 or sometimes 5 or 6 probe simple EEG, and not only do we use it in assisting and augmenting our diagnosis of significant moderate to severe grade 2 or 3 HIE, and in relation to referral for babies for therapeutic cooling, but as a diagnostic tool when we're not sure of the clinical appearance of the seizures, of whether they are actually true seizures or not. We found it very helpful. It is also helpful in the ongoing monitoring of a baby, because, as I've already mentioned, on some occasions babies can have subclinical seizure activity that is not clinically evident, but may be picked up on the CFAM machine. So that's very helpful, and it's very helpful indeed as well. We can share that with our colleagues in different hospitals. We can review the findings on the screen together. Everyone looks very relaxed in that picture, which is the way it should be, of course. So finally, I wanted to bring to you a rather unusual case that probably none of us will see in our lifetimes, but I certainly haven't heard of. It's an unusual case, but it was just interesting in its own place that I thought I should bring to you. This was a baby born back in 2019, so 5-6 years ago now. Young parents, they were non-consanguineous British parents. It was their first baby. The 20-week anomaly scan, which has now been done in the last, I guess, 25-30 years, showed what appeared to be a female fetus, which is important for as we come to later. There was evidence of an absence of the corpus callosum and a suggestion, even on that early scan at 20 weeks, of a possible underlying neuronal migration disorder. There were significant concerns regarding the gyral pattern and the appearance of the brain. And that had been flagged up, that had been obviously confirmed, first of all, by referral and review at tertiary level by the fetal medicine team in Leeds. And a neonatal alert had been raised to our team by obstetrics as to these findings. Obviously, within that, there wasn't enough to give us a confirmatory diagnosis, and parents at that point had declined more invasive testing, such as amniocentesis as such, and continued with the pregnancy. So we were aware that there was potentially an underlying brain abnormality with this baby, and which we would investigate when the baby was delivered. So actually the baby was delivered by normal vaginal delivery at 39 weeks. They were well grown. From memory, they were nearly 3 kilos. That was June 2019. They were born in good condition, and of note, no resuscitation was required, which made the likelihood of an hypoxic insult quite unlikely. And the baby initially remained with mum. It was obviously clearly a plan to review the baby and monitor their blood sugars and obtain some form of more formal brain imaging. But as the baby remained well, they were happy to for them to stay with mum. However, our neonatal team, one of our nurse practitioners, was called back at just 40 minutes of age, and this was very unusual that this baby was noted by the midwives to possibly be fitting at that point in time. Our experienced nurse practitioner observed generalized twitching with episodes of increased muscle tone that were generalized, and the baby was immediately transferred to the neonatal unit, placed on monitoring. As we've said, we ran a blood sugar that was slightly low at 1.8, but was corrected with a dextrose bolus and remained normal thereafter and was not an issue. but the baby continued to fit in spite of normalization of their blood sugars. They were cultured and covered with IV antibiotics. Subsequently, those cultures came back with negative results, and antibiotics were stopped after 36 to 48 hours. And as per our policy, our first line medication, we loaded this baby with 20 milligrams per kilo of phenobarb intravenously. On further review of the baby, it was noted this baby had really quite obvious ambiguous genitalia. We'd been informed antenatally that this was a little girl, and in fact the parents had called her Daisy already, but they'd already name picked out for her. But we had to speak to them fairly quickly to say, listen, we cannot be entirely sure of their karyotype because of the ambiguous genitalia. So an urgent karyotype was sent along with an array genetic testing, and the karyotype came back that actually this baby was XY, was karyotypically a male rather than female. And for young parents, I was just simply amazed how quickly they took on board and accepted the situation. They had spent 9 months considering that they were having a little girl, and really took on board that yes, we had a little boy, and clearly a little boy with very significant underlying problems. We obtained an urgent ultrasound on that first day, and I think only a day or so later we were able, the baby was not significantly obtunded by the seizure activity, as far as they did not drop their saturations, and they were able to self-ventilate. So we were able to obtain a brain MRI at local level, and that confirmed sorry, my spelling's gone there, the absence of the corpus callosum, but more broadly speaking, an appearance of lesioncephaly. I've got a picture of lesioncephaly in the next slide. So a very abnormally formed and poorly differentiated brain. Sadly, this baby continued to have breakthrough seizures in spite of us loading with phenobarb and actually phenytoin as well. And this was escalated on the conversation with our own local neurology special interests, paediatricians, to the addition of Keppra. And sadly, this baby continued over the weeks to come to have a progressive breakthrough refractory seizures in spite of multiple combinations of anti-epileptics. We worked in very close liaison with our tertiary paediatric neurology colleagues over at Leeds, who were obviously suggested a myriad of different combinations of treatment, but these fits remained intractable, sadly, in spite of everything. And there's just an overall picture of a normal brain and lesioncephaly. As you can see, a very, very smooth cortex compared to the normal gyral pattern that we're seeing. The ventricles themselves are abnormal as well, with absence of the corpus callosum in this case. And just and the grey-white picture is very, very different. And clearly we had a baby that had a significant neuronal migration disorder. And actually what we discovered, this came through really quite quickly within a couple of weeks from our array. The genetic lab phoned us back and confirmed something called X-lag syndrome, which none of us had ever come across before, but it essentially stands for X-linked lesioncephaly with ambiguous genitalia. So clearly this was an X-linked recessive disorder with our brain abnormality and the ambiguous genitalia as we've seen. As with most cases of this condition, it's a sporadic mutation. Mum and dad, or it would have come from mum, but she was tested and was not a carrier as such. Sadly, the fits were only transit controlled for a matter of a few days at a time, despite multiple drug combinations. And ultimately, this baby moved from our own care up to the children's ward, and we had parallel planning of with our palliative care hospice locally in the reorientation towards palliative care, and actually baby passed away quite peacefully after about 4 months in the local children's hospice, which is a really rather sad story, but nonetheless an interesting and very unusual one.
Thank you very much, Dave. That was a really nice presentation of all of the common causes of seizures and how to treat it, with a really nice treatment algorithm showed. I'd like to hand over now to Dr. Juliet and Jennifer from Lira Regional Referral Hospital in Uganda, and they are going to talk to us about their experience of neonatal seizures.
I'm called Alaba Jennifer, a nurse at Neonatal Intensive. Privilege to share a case of neonatal seizures managed from our unit. Is to share the experience of managing a newborn infant presenting with seizures in resource-limited settings, and also to share the protocol of management of a newborn infant presenting with seizures in Uganda. Case summary: when our male baby was referred from a nearby private clinic, born at 38 weeks of gestation, delivered by emergency cesarean section, distress. Her PEGA score was 8 at 1 minute and 9 at 5 minutes. So on admission, sorry for that, the baby wasn't in a fair condition. The baby was sick looking, no obvious abnormalities, pink and well hydrated. Baby was hypothermic with a temperature of 34.1 degrees Celsius, respiratory rate of 58, heart rate 136, and SpO2 of 90% on CPAP. The baby was brought on free flow oxygen 2 liters, so we had to shift immediately into CPAP. So the saturation of 90% was taken while the baby was on CPAP. Neurological, baby was unconscious, AVPU of P, flat anterior fontanelle, no grasping and suckling reflex. Baby was grunting with subcostal retractions, chest was clear, SpO2 was 90 to 96% on CPAP. The capillary fill was less than 3 seconds, with the heart sound 1 and 2 hard with no added sounds. Her abdomen, there was nothing significant, was soft, of normal fullness, and the cord was well ligatured. The impression was a term baby with meconium aspiration syndrome, so we're querying severe birth asphyxia, much as the APEGA score was 8 to 9. The Thompson score was 17 on admission. Next slide. So the management plan was to keep the baby on CPAP, IV ampicillin, Genta, and dextrose 10% was initiated, a total of 60 mils per kilogram for 24 hours. Since the baby was very sick, mil per oz was recommended. So baby was reported to have had recurrent seizures, which was characterized by tonic-clonic movements of the limbs, which was lasting about 1 to 2 minutes and occurred every almost 1 minute, almost every 1 hour. So on general examination, baby was sick looking, febrile on touch, with a temperature of 39.4 degrees Celsius. Baby was mildly dehydrated, with the RBS of 4.6 millimole. And this was corrected immediately using dextrose 10%. On neurological examination, baby was still unconscious with a flat anterior fontanelle. Grasping and suckling reflex was still absent. On the respiratory system, respiratory rate was 72 with subcostal retraction. Chest was clear with a SpO2 of 85 to 93% on CPAP. Capillary refill was less than 2 seconds with a heart rate of 121, beats per minute, heart sound 1 and 2 was heard with no added sounds. Per abdomen there was nothing significant. So the management plan for day 2 continued with CPAP and phenobarbital loading dose of 20 milligram per kilogram body weight was given with a maintenance dose of 11.5 milligram. We continued with the previous treatment, which was ampicillin and gentamicin. Fluids was calculated for day 2. A total of 80 mils per kilogram body weight was given, 15 mils every after 3 hours. Nasogastric tube was inserted for feeding, and express breast milk of 7 mils was given every after 3 hours. So we were to monitor and record vitals every after 2 hours. So investigations were requested. We had a complete blood sample taken off for complete blood count, blood smear for malaria parasites, and a sample for serum electrolyte. So after giving a loading dose of phenobarbital, 1 hour later, the baby was still convulsing. There was no change. So another loading dose was given of 46 milligram. And after 2 hours, the baby was still convulsing. So this was shifted, the anticonvulsant was shifted to phenytoin at 20 milligram per kilogram body weight. 3 hours later, the convulsion still persisted. So another loading dose of phenytoin was given. After that, the convulsions stopped. We continued with a maintenance dose of 11.5 milligram. So on day 4 of admission, the main concern was persistent high-grade fever with jaundice, but there was no convulsions reported in the last 12 hours. So on examination, baby was still sick looking, febrile, temperature of 39.4 degrees Celsius, moderately dehydrated with a Prama zone 2. Neurologically, baby was still unconscious with bulging fontanelle. This time the fontanelle was bulging, the anterior fontanelle. Grasping and suckling reflexes were still absent. Respiratory rate, 69. With subcostal retraction. Chest was clear with SpO2 of 90 to 95% on CPAP. On the cardiovascular system, capillary fill was 2 seconds, heart rate 147, heart sound 1 and 2 were heard with no added sound. For abdomen, there was nothing significant. So the impression was hypoxic ischemic encephalopathy, neonatal meningitis, neonatal jaundice, and possibly we were also querying ABO blood incompatibility. So the management plan was to keep baby on CPAP, but then antibiotics was shifted from ampicillin and Genta to IV cefotaxime and IV amikacin. Having the conversions having ceased, we continued with the maintenance dose of 11.5 milligram of phenytoin for the next 2 days. So the total fluids was hiked to 100 mils per kilogram for the weight, and the express breast milk, we were giving 9 mils every after 3 hours. Phototherapy was started, and we were to monitor and record vitals every hour since the baby was very sick. So the investigations were requested, and the lumbar puncture was done. Sample for CSF taken off for CSF analysis. However, the sample turned hemorrhagic, and the analysis wasn't done. So electrolyte sample also was taken off for electrolyte, and we were able to get the liver function test and the renal function test done, but there was nothing still significant in those results taken. So these were our results, which we got. The blood side for malaria was a negative. The CBC basically had anemia. The baby had anemia, a HB of 8.2 in units. That is very low. So blood transfusion was done. Baby was blood group O positive. So the baby was transfused. And also there was a thrombocytopenia. Baby was given a supportive management. Thank you so much for your time. Let me hand over to my co-presenter, Dr. Juliet.
Thank you very much, Dr. David Gibson and Jennifer, for the wonderful presentation. I'm Dr. Juliet Adongo. I'm a pediatrician at Lira Regional Referral Hospital in the northern part of Uganda, serving the 10 districts of Lango sub-region with a population of 2.5. Our annual delivery is about 1,258, and all these facilities, they refer to the facility. So the neonatal intensive care unit is a level 2 special care nursery. The newborn unit with an average of 80 admissions per month. We are equipped with 4 incubators. We have 3 radiant warmers, 1 CPAP machine, phototherapy, and KMC bed. The picture is taken from the NICU. Just behind them is the NICU. Most of our babies actually, we use kangaroo mother care, and because of the few radiant warmers. So that is the corridor. The NICU is it sits on a room which is about 5 square meters. So I'm going to discuss about the case which my colleague Jennifer has presented. The case of the baby which was managed at the facility. Actually, would like to appreciate the role of the clear history and the investigation that this child got, because most of the management was basing on the history, the referral note, and then what was got, even the seizure history was got from the mother, and the diagnosis management was basing on the history. The results were actually obtained 3 days later. And what poses a question is, what was the unders? This was a child. This was a baby who was born by emergency seizure due to emergency C-section due to scored 8-9. Possibly there was an element of asphyxia. It was not documented whether back or not from the referral note. But at admission, baby was in severe respiratory distress. So we also thought possibly there was an element of hypoxia, which was contributing to the seizures. And then baby also developed jaundice. The bilirubin-induced neurological damage could have caused that. And then we also had infections. The baby was actually predisposed to infection basing on the history. And also with a mother with obstructed labor and several interventions at the time of birth. And baby was also born through meconium stained liquor, predisposed this baby to infection. So there was that benefit of doubt that could this baby have developed sepsis and eventually got meningitis, which made the child to seizure. So these were multiple contributing factors. And I think my co-presenter, Dr. David, talked about the several compounding factors. This made this actually a very challenging case and complex case to manage. And the important learning point from this case, in our opinion, was actually that we appreciated that for us to effectively manage seizures, we require a very clear history, and then clinical examination is key, documenting the seizures. Unfortunately, in our setting, it is the mother who reports the seizure, and we were talking of the role of taking photos of the seizure. So it's normally a narrative because most of our clients do not actually have the smartphones and they cannot take. So it is verbal report from the mother. And if a nurse is available, can witness and confirm. So this makes it a bit very complex. And then also it requires timely investigations. For example, if the seizure is due to hypoglycemia, the metabolic cause, would need to intervene immediately. This we can routinely do, but in the event that it is another cause, for example, electrolyte imbalance, for example, in this case, the results of the electrolytes actually came 3 days after, so which we could not intervene in a timely way. So we appreciated the timeliness of investigations. We also appreciated that if we followed the protocol, because we followed the protocol of management, this was discussed by Dr. David, the phenobarbital as the key drug, and actually the seizure, we managed to arrest the seizure. The seizure stopped. So this was actually very good. And then the time the child had the third seizure, we also, it was a bit complex for us because we were anticipating this was a very sick child, and possibly we needed some other form of respiratory support because we possibly may need to sedate the child. So we were in a sort of panic in the event that the seizures had progressed. We may need a facility to support respiration intervention like mechanical ventilation, but most of the facilities in our setting still do not offer that. We use CPAP as the highest level, and rarely do we do mechanical ventilation because we need to transfer the baby to the adult intensive care unit, which most of the cases, the beds are occupied. So how it was done well, or an area for improvement. So we actually acknowledge the efforts which was put on monitoring and the nursing care in this case, because the sequence of events was well documented. We could get the narrative. Also, we appreciated the referral facility for giving the pre-referral treatment. We noted baby came actually when the saturation was between 80 to 90, and the child was on oxygen. So this was actually done very well. And what didn't actually go well was the investigations. What could be done immediately was the random blood sugar, but the other form of investigations did not come timely enough to make the decision. So in that particular case, we were unable to know the underlying cause. For example, my co-presenter, the CBC, he had anemia. So we thought possibly if this child had intracranial hemorrhage, we were unable really to confirm. However, the child physically did not have any other signs of bleeding on the skin. Yes. So, and then the other gaps also, there were gaps in referral history. Just as I mentioned earlier, we did not know what intervention did the baby require resuscitation at the time of birth or not. This was not documented. The maternal history was a bit deficient. We couldn't assess the other risk factors in case mother had infections. I think Dr. Gibson talked about the torches as one of them. Syphilis is quite common in our setting, but we did not have this history. It was limited, and yet actually it is key to rule out any predisposing factor to infection. And then also there was a gap in the investigations, the timeliness, especially of the investigation. The electrolyte was actually not done. We managed to get results of urea and creatinine. The extended electrolytes like calcium, potassium, all this, we could not access the results readily in our facility. But in other private facilities, this may be accessible, but in our setting, it was a bit challenging. And then we also talk of the CSF and blood culture. The CSF find was hemorrhagic. We couldn't really assess, was it the technique or really if the child had intraventricular hemorrhage, would it have led to that? That was really a bit difficult for us. So all this was not done well. And then last but not least, we had limited choice of anticonvulsant to choose from, though we know that phenobarbital is a wonder drug. It is, and I'm happy to know that in the UK, it is also the key drug. So in our setting here, we have phenobarbital as the key drug for management of neonatal seizures. However, this only comes at a level of the referral facility like Lira. But we have Health Center 3 and Health Center 2s, which do not have access. So in the event that the child had started convulsing earlier, they would not really administer it. So briefly, just to the common causes of seizures in our setting, commonly is perinatal asphyxia, almost amounting to about 80% of the causes of seizures is either asphyxia or infections. The two may go concurrently or both of them may compound. And then we also have the common cause is we have hypoglycemia as the most common metabolic cause. We get hypoglycemia quite common. So this we routinely test if a child starts seizure, even it's in our protocol. Once there is a seizure, we do the random blood sugar. However, it's challenging. We have the glucometers, but sometimes the strips run out. So it is in a protocol. If the strips are not available, then our protocol of management, we start with correcting hypoglycemia. What we may be common, but rarely diagnosed because of challenges of investigations, the electrolyte imbalances, as we saw in this case. We can't say it is quite uncommon, but I think if we are able to run the test, we get the diagnosis. And then we have intracranial hemorrhages, the congenital malformations, and then the torches. These are rarely diagnosed in our setting. And then the drug withdrawal, toxin exposure, and then neonatal epilepsy syndromes. This one is majorly we diagnose with exclusion. And since it's challenging for us to diagnose all the other above causes, so this rarely comes among our diagnosis. So commonly we have the other three, perinatal asphyxia, infection, hypoglycemia, and then also if there's bilirubin-induced neurological damage. Those are the most common one we encounter in our facility. Actually, basically, we follow the ABC protocol and we correct with oxygen administration. Then we assess and for treatment of the underlying cause. And for the management of seizure, we use the anticonvulsant drug, phenobarbital, as the first line anticonvulsant. So I extracted this from the clinical protocol for management of small and sick newborns. It briefly actually describes the protocol of management of seizure in Uganda. It is used in Uganda, not only at Lira Regional Referral Hospital, but mostly explored by the government facilities. This is what we use. We said initially we check the random blood sugar. If it's less than 2.6, we correct the hypoglycemia with dextrose 10% as a bolus. And then after that, if seizure continues, we give a loading dose of phenobarbital intravenous, 20 milligrams per kilo, which we give slowly over 20 minutes. And if the seizure continues, we repeat the second dose of phenobarbital. Still, we repeat 20 milligrams per kilo, slowly over 10 minutes. In the event that the seizure continues, we administer phenytoin. We now change to phenytoin infusion if it is available. And if the seizure continues, ideally, we should be referring to a level 3 neonatal intensive care unit, but we would really want to initiate the child on midazolam infusion or any other intervention which requires, but most cases we rotate among the phenobarbital and phenytoin. And this has done wonders for us because most of the seizures actually rarely progress to status epilepticus, which require the other intervention. But for the few that do, then we need to transfer them to a higher level of care. Our experience with this, with the management of seizures and also the application of our protocol in our setting, as I mentioned earlier, the suggested testing of random blood sugar is sometimes challenging due to stocks outs of scripts for glucometers. However, we have overcome this by, in case we cannot get the strips, on the protocol, we just give the glucose and we correct the hypoglycemia. And then the challenge also is the turnaround time of the test, which may take, it is challenging to get the test results within 24 hours, based on the facility we are in. And then the limited choice of anticonvulsants, which we have to choose from. And then we also have a challenge with monitoring and nursing care because most of our mothers, our patients, actually our babies in the NICU We have the nurses on call. Per shift, we have one nurse on attendance who may not be able to observe all the others. So as I mentioned earlier, most of these seizures are reported by the mothers. And I think from Dr. Gibson's presentation, they said the seizures may actually be subtle. So the mothers sometimes mistake these seizures as they don't notice that it is a seizure. A child may be having lip smacking, and the mother may be thinking wants to breastfeed and would not report that. So this has been actually very challenging because we don't have a full-time nurse to monitor that. And then we'd also want to document the frequency of the seizures. This has been a big challenge because of still the nurse to patient ratio. We cannot document. We take a narrative after some time what had already happened. So these are the few challenges. But however, the experience with the use of the protocol for management, the outcome has proven to be actually good, and the outcomes really help to save the neonates, even in the absence of these investigations. Thank you so much for listening.
Thank you so much. So thank you, Dr. Juliet and Jennifer, for an amazing presentation. And it's so good to hear just different causes of neonatal seizures. So I think we've seen, in summary, we've seen a case of a structural brain anomaly from Dr. David. And then I think what Dr. Juliet and Jennifer have shared is that actually you can have a baby who can have many causes of seizures. And for me, it's about treating the basic, treating the treatable. And what we can see is that we always have to remember the blood sugar, because that's a really common cause of neonatal seizures. We have to think about ABC and give them adequate respiratory support. And then it's about treating infection and then using as much of the resources that we have available in terms of the investigations. And obviously, if we have got in high resource settings, things like ultrasound machines or EEGs, they can be really helpful. But I think what you've both demonstrated from the Ugandan and the UK perspective is that our treatment and management plans are actually very, very similar, with our first treatment being phenobarbital, and then obviously either phenytoin, and then we're lucky in the UK we've got very good availability to Keppra, which is our third line anticonvulsant. There's been some really, really good questions and comments in the chat. Just a date for your diary. The next scale grand round is on the 11th of April, but this has been the most well attended grand round we've had. So 215 people listening about the causes and treatment for neonatal seizures. So yes, if there's no further comments and questions, I just want to say another really big thank you, Dr. Juliet, Dr. David and Jennifer. And thank you to everybody for attending, and thank you to everybody for all of your questions and comments. And hopefully between myself, Kathy and Matthew, I think we've tried to answer all of your comments. So thank you very much for attending, and we look forward to seeing you at the next grand round in April. And I wish you all a very happy weekend. Thank you very much.